You're listening to the Animal Heartbeat. My name is Kieran Bourget.
Hi, and I'm Jose Lobumatos. This is the world's only podcast dedicated to veterinary cardiology. Hi, everyone. Welcome to the Animal Heartbeat. We have another great guest with us today, Dr. John Bonagura. Dr. Bonagura is a double-boarded specialist in both cardiology and internal medicine by ACVIM, and is a fellow of the American Society of Echo. John was the head of cardiology and interventional medicine at Ohio State for much of his career, and most recently has been working at both North Carolina State University and Colorado State University. John has achieved many great things during his career, has been the recipient of multiple teaching and clinical awards, and has pioneered really echo assessment and echocardiography in veterinary cardiology. John, thanks very much for joining us today. It's a huge pleasure.
It's a pleasure, John. Thanks for inviting me.
John, I think I have two professionally related things to thank you for, particularly. One is being the mentor of my mentor. So I owe you a lot. I don't think my cardiology training would be where it is without Virginia's input, and therefore without your input. And the second is for your work on Kirk's current veterinary therapy, which I think got me through every medicine exam or every medicine case I had to run up against and deal with.
Well, two comments. Number one, Virginia didn't need any training. I think she trained me. I was her titular advisor for ACVIM, but we had a fine collaboration for 5 years at Missouri and a number of years at Ohio State. And she's still a very close friend. In fact, we are co-chairs of this ASE guidelines writing committee for transthoracic echo. And in fact, I saw Virginia last week at ASE, so it's always great. And you're also lucky to have her back in the UK for so long now. And as far as Kirk is concerned, I remember receiving that textbook after being an author and a section editor on a picnic bench in Vermont when I was speaking, and Dr. Kirk and his wife came up to me and said, "Can you have lunch?" So I think we had hot dogs on a picnic bench. And he said, "I'm looking for someone to take this over. And so would you be interested?" And that's how it happened. And I spent a number of days in Helen and Bob's kitchen in Ithaca, sometimes discussing the book. So back in the days when things were less digital and perhaps simpler and sometimes better.
Yeah, I think books like that are so much hard work to put together, and I think people don't realize that the challenge of the editor or the challenge of the section editor even, and there's so little reward immediately compared to doing a lecture, or you don't get the feedback on it, I guess. But I think the impact of books like that is massive, and not to be underestimated.
Well, they used to be. It's really interesting. So right now, so Brian Skansen is now the new senior editor for Kirk, and I'm helping him. So I'm doing about half of the editing. And it has been, I'll just say, challenging to get this book launched. And it does make me think about the transition of textbooks and whether, for example, young authors should even think about writing a textbook. My simple advice would be no. And there was a time when Kirk was the largest selling veterinary textbook in the world.
Yeah.
And now its sales are dwindled. If you ask the average veterinary student, which I do because I do a lot of locums, I ask them, how many textbooks do you own? The answer on average is 2.5. Now, some of these don't include digital textbooks, but if you were to ask a student to find something in a textbook, most of them are unable to do it efficiently, even though it's probably one of the most efficient ways to find information, as long as the textbook is relatively up to date. So, I think the landscape has changed. My advice to an author who just has to tell everybody what they've experienced and think would be put it online, control it yourself, and change it when you want. And then if you don't like it anymore, you can turn off your website. But it's an extremely challenging landscape of publishing right now. We'll just leave it at that.
I've heard it's all podcasts now.
Yeah, I've heard that too. Yeah. Yeah. And the information is so genuine and vetted on podcasts, so it makes it really good.
That's a shame, because what I always loved about textbooks is you can get the author opinion, right? Because in a paper, people need to be very careful not to speculate anything, be black and white. And reading a textbook, there was at least some margin for the author to talk about their own experience. It's interesting you say that, because I was hoping the textbooks will come back now that you have all these apps like Speechify and so on, that you can read PDFs and read textbooks, and people can have the books read for them while they are driving and so on. I was hoping that some textbooks, people would start going back to the textbooks, but yeah, it's a shame. I think it would be sad if we lose that. Yeah.
Yeah, I don't know. And to be fair, it's hard on publishers as well. I mean, it's hard to get authors to respond. It's hard to get them to turn their chapters in on time. When you have, I think if you have a textbook that has minimal authors, you're in a better position. If you have over 200 authors, such as CVT has, it's a challenge to get that wrestled. I'll just leave it at that.
Yeah.
So, John, you talk about echo guidelines there and allude to this collaboration with ASE. And we wanted to talk to you particularly about echo, because this is something that you're renowned for. And I've seen some of your lectures on echo, and really they're unrivaled, I think, for me. Tell us a little bit about the need for echo guidelines. Do we have any as veterinary cardiologists? Where are we with that, and what does the future hold for us?
Sure. So we have echo guidelines from Bill Thomas's group. It was, I want to say, 5 or 6 people who were doing echocardiography at the time. I was actually on that committee initially, but as were others. And then it eventually evolved where somebody said, let's have guidelines. And the members of the ACVIM echo committee at that time wrote those. Bill Thomas was a spectacular cardiologist and just a really, really bright. He's a very, very bright man, and I think it's actually hard to criticize much in those guidelines. If you look, we're actually using some of those drawings again and reformatted, as many people have in textbooks and other articles. What I do think we have some difficulties are when so many people are doing echo now. So these guidelines are not being written for cardiologists. I mean, let's be honest. It's going to be hard to change a cardiologist's approach. If you hold the transducer index marker under your index finger or your thumb, you're probably not going to change. And so this is really more for new learners, residents, and people who are doing entry-level echo. It's also because ASE is a Big 10, and ASE, although they have a lot of demands on their guidelines office, so which is one reason why things have taken so long. But ASE is extraordinarily welcome to veterinary medicine. I mean, when we were at ASE Nashville, there were about 50 veterinarians there. They gave us an entire day in our own room, and our chairs were some of the most important people and well-known people in medical echocardiography. I mean, it was tremendous, and the collaboration that they've sought has been wonderful. And I would encourage any veterinary cardiologist to join. I know the European group has a diagnostic imaging specialty and society as well, but ACVIM is really not just American. I mean, it's really international, and they welcome veterinarians. It's a great meeting to attend. You don't feel like you're out of place at all. I think one reason for that is, I believe medical doctors who focus on echo have a very egalitarian approach. They depend so much on medical sonographers to perform these studies, right? And so they're used to dealing with people who are not just physicians, and they deal with them, very professionally, politely, and very, data and quality driven. It's a great group and a great meeting. It's hard to find a better meeting than that, to be honest with you. So as far as guidelines are concerned, where are we? So we have 36, 37 drafts written of these guidelines.
Wow.
Yeah. And a logical question would be, why don't you just post them and let everybody read them? And I wish we could do that. But one thing that ASE does do is they embargo guidelines. They do not want them released prematurely. One of the reasons that you saw that recent survey done by the Veterinary Special Interest Group of ASE, which is mostly people who are on the guidelines committee, was we were trying to get feedback from around the world about what people do when they echo, because we did want to be mindful
Right.
of that. We got over 300 respondents, I mean, which I thought was a fairly good sample. I mean, that's a long survey. It took, probably an hour to do if you did all the questions. So I think the current plan is for these guidelines to be presented and hopefully published in JACE in the early part of 2016. That's the current schedule. We have another deadline coming a week from Wednesday, and we'll see how we do there. But we're getting close, very close.
So that's early next year.
Yes, that's my hope is. And
Right.
and again, these will be guidelines. I mean, you can imagine the things we discuss. How do you measure the interventricular septum of the cat? I mean, Jose, that's probably, you live that world every day, right? What's the best way to measure the left atrium? So Lance, of course, and I are probably long axis folks because that's what we came from, in Ohio. And, but, I think the guidelines are mindful that the most common way to do it is a short axis. So I think both of these will be, I believe both of these will be recommended. We don't have final approval of these yet, but in current form. So we're trying to be mindful of what people do. And then you can think about short axis, M mode. So like, I know that I listened to one of your podcasts, and Kieran, you might have said you do long axis measurements on 2D only of the LV.
Yeah.
Well, so most people on survey only do a short axis M mode, but I'm in the camp that you make mistakes frequently if you only do that. So you should really look at both long and short axis, whether it's M mode or 2D, and see how well they compare. If they don't compare well, there's been an error made in one view or the other or both. So I think these are the kind of comments we're trying to advance.
Yeah. First of all, thanks so much for all the work you are putting on that, because it must be a huge amount of work.
Huge amount of time.
And but you're saying that maybe the guidelines are not focused or targets for cardiologists, but would be great. I think one of the major things really is that we all measure stuff differently. I think we believe that we do more or less all the same things and we measure the same way, but we don't. And we see that whenever we submit a paper and we feel like, well, this is the way that everyone would do it. And then the reviewers have completely different ideas. And so we are doing stuff differently. But regarding measurements, we have been looking recently into interview agreement, and it matters that the agreement is so poor between different views, not to talk about modalities, M mode and 2D. So then it's difficult to compare the papers out there, right? Because if someone phenotype the cat based on short axis and someone else phenotype the cat based on long axis, the cardiac phenotype will be different, the results will be different. And if we are start looking, just sorry for the cat bias, but if we are start looking now at wall thickness and how certain drugs may affect wall thickness, measurements will be more important than ever, right? How we measure will be really important. And so I would really hope that with the guidelines, certainly not everyone will agree. We will never agree with everything. That's fine. But at least that we start following them. And then when we read a paper, we know, okay, the materials and methods follow the guidelines. So we are all doing the same thing. I think it will be very helpful to be able to compare papers.
Right. I totally agree with what you're saying about measurements. And one of the areas that's been rewritten the most has been the measurement sections. And so we have very specific recommendations for timing of diastole and systole because they're not consistent.
That's important, isn't it?
And one of the challenges there is, and this is something that I discuss with my colleagues at CSU and NC State all the time, is when you force feline images, especially to DICOM, you're lucky if you get 2 frames that are even close to the QRS, right? I mean, the image literally jumps. So, for me, one of the recommendations that I hope will be accepted will be if you're not going to have raw data. So in Europe, you use a lot of GE, and in the US, GE is very popular, and I have both. But Philips is more often used in bigger institutions now, and that means it's forced to DICOM unless you store in Philips raw data, which they almost never do. Even pediatric cardiologists have that problem because IT doesn't want to give them the 50 or 60 frames per second in the packs that they might be able to store. So to me, if you're doing a CAT and you're not going to get raw data, you better measure on the cart before or store true end diastolic images before you measure later. So the next point would be, how many endocardial borders do you measure? So how can you compare M-mode normative data where you're doing a leading edge technique with measuring blood to tissue interface when the border of the endocardium in some studies can be 0.3, 0.4 millimeters, right? Even if you're not including the false tendon. I also listened to Jens' podcast. I do think the word false tendon, by the way, doesn't bother me.
No, nor me, but it's a big campaign for Jens, I think. That
Yes, yeah,
banned.
they're not. I mean, I think we know my understanding of them histologically is that most of them, maybe not all, but most of them are actually Purkinje fibers covered by myocardium and endocardium. And so they're part of the conduction system as best I can tell. So I think that, how we measure is super important. And so what we're saying is if you're going to compare M-mode data to your study, you need to measure only one endocardial border. And I think the current draft suggests, I'm not supposed to give too much of this away, but the current draft, again, not approved, suggests you measure the thinnest border. And so if you're measuring on 2D. Now, if someone wants to do a whole study and measure blood tissue interfaces beyond the one that's only been published so far, then I would say that's great. But right now, how do you measure a blood tissue interface and compare it to a leading edge, especially on the feline septum? So I've listened to enough of these podcasts to know that you guys like a little controversy. So I mean,
I'll like a little controversy.
I'll throw it out there.
Phrased politely.
I just don't believe 14% of cats or 18% of cats have HCM. I think it's an aberration of how we measure the septum mostly. And if your criterion is a single segment that measures 6 millimeters, that's and I remember Jens talking about that. He said you can't just look at the measurements, right? You need to look at the whole cat echo. You can't just focus on that. So
I couldn't agree more. Just to share. So during my PhD appraisal, one of the examiners was a human cardiologist. First question, first comment he said was exactly what you said. He said, it's impossible that 15% of cats, 1 in 7 who have HCM, you are not measuring them properly. And he was saying, we have problems between 12 millimeters and 15 millimeters. And we are talking about 3-4 millimeters. You are talking about half a millimeter in a cat with a heart rate of 220. Totally. I couldn't agree more. And
it's very interesting, isn't it? I was doing some lectures recently and I was forced to look back on some old data of mine and think about it, and actually showing some images, very high quality, of the septum, looking at the right ventricular apparatus, looking at the attachment of false tendons, LV bands, looking at accessory papillary bundles in short axis. And I spent a long time in this lecture talking about all these different things and effectively said, I think some of the work that I measured for a decade ago was probably wrong because I wasn't measuring it right. And that's a big admission to make, isn't it? It's quite a big deal for us to hold our hands up and go, you know what, maybe we've overdiagnosed this.
Yeah, it's tricky. Because HCM per se is in 70% of people will also not progress. And so I think it's really difficult to draw the line, right? Because in fact, most people with HCM will have normal life expectancies. And so it's really difficult. But I do agree that I think we overmeasure. And to me, honestly, the eye opener was when we started doing contrast echo to measure alveolar thickness. The walls look very, very thin. Look much thinner. It's crazy how much thinner the walls are. And so certainly we are including RV trabeculae with stuff that is not true compact myocardium, which is very, very interesting. Well, fascinating.
We obviously need guidelines, eh?
Two points that you made. So one is, I don't think it's an accessory papillary muscle. Can I ask you to look up the anterior lateral bundle of Moulaert? I can't pronounce it, but I think it's Moulaert. That structure, I believe, is present commonly in both dogs and cats. It will hypertrophy with the rest of the left ventricle. It's a normal structure in humans. It's been known for many centuries, actually. And if you look there, we often see on the short axis view, around 2 o'clock or so, there'll be another accessory papillary muscle or bifid papillary muscle. I don't see any chordate tendon going to it. I do see false tendons going to it. I think it's just a normal muscle bundle that's been identified in humans for, an extremely long time. And I think
1976, John, is what Google's telling me right now. Sorry, what the Bodleian Library is telling me.
Did you find it? Did you find it?
Yeah, 1976. The lead author is the chap who the bundle is named after. So
Yes.
humble guy.
Yeah.
A hitherto unrecognized muscle bundle in the left ventricular outflow tract is described in the 2 o'clock position. So today's a school day, isn't it, guys?
Yeah.
For me, at least. Yeah.
Yeah, and actually, according to Dr. Kislow at Duke, so if I were to impart any suggestions to any young cardiologist, it would be to spend as much time as you can with pediatricians and medical doctors who do adult cardiology, because that's how I learned cardiology to a large degree. I mean, my training program would have never been approved today, but I learned so much by going to the medical school and the Children's Hospital. And I think Dr. Kislow in one of his pig labs that I attended at Duke showed that and found a reference, that was centuries old for that bundle. It's the same question comes up in people as well. But getting back to the whole issue, will the guidelines offer specifics about measurements? Yes, they will. I mean, how many ways can you measure LAAO short axis, right? You can measure it at what you hope is protodiastole, but often is not. Of course, look at some of the published images and you see the cursors on the P wave by the time that they actually measure it. You can measure it pre-P, you can measure it at the R wave. So we'll provide what we believe are some specific recommendations. People don't have to follow those, but we are going to try to be specific. I think even for DCM, I mean, you guys have probably read that review that Lance and I wrote about DCM and JVC. And one of the things that I found really interesting was when we went back and looked at what we consider completely healthy dogs, which of course is always an issue, but these were healthy dogs. I mean, there's so much dysynchrony normally seen on an M mode of the left ventricle. And so if you're measuring the traditional way at the nadir of the septum, you're going to overdiagnose DCM like crazy. And then if you make an even bigger mistake and cube it, regardless of the Tycholt's correction, you're going to way overestimate the volume. And then you're going to say, oh, the dog has left ventricular systolic failure because his end systolic volume index is too high, but you've measured the volume perhaps incorrectly. I think Tycholt's may work for a healthy dog. I don't think it works at all for a dilated ventricle. I think there's some papers from both Paris and from Sweden that demonstrate that.
John, can you just remind us how would you recommend to address that LV desynchrony when on M mode? Because you describe it really nicely on your paper, but with Lance, can you just tell us how do you approach that when you are doing an M mode and there's a desynchrony between the intraventricular septum and the free wall?
Sure. So, I mean, the way I look at it, we have multiple ways we can measure the LV. We can start with our eyeballs, right? So what I tell residents to do is get a good short axis view at the high papillary muscle level. And, we don't have a good chordal level in dogs and certainly not in cats, right? So when we've polled people, almost everybody measures at the high papillary muscle level, which for me means you've gone up to the mitral valve and then you've come a little bit apically till you just see some bright insertions in the papillary muscle. And that's where almost every veterinary cardiologist measures based on these surveys and my personal questioning. And that's how I do it. So if you look at that and you freeze it in diastole and freeze it in systole, you get an idea subjectively of fractional area change. I think looking at the long axis is very deceiving. What physicians often do is focus on the mitral annulus and the posterior wall and look how it moves apically. They actually look at that more than they do sort of the, I guess you can't see my hands, but from septum to free wall, which is what we measure with M mode. But if I have a poor fractional shortening or a borderline one, the next thing would be to measure a fractional area change. But of course, that doesn't include apical basilar. So the next thing would be to do an estimated either one plane or two plane volumetric estimate with Simpsons. If you can get a good long axis 4-chamber from the right and a good apical 4, trying not to foreshorten it, cutting off some of the atrium to optimize the LV, I would do that. And then I do longitudinal strain. I mean, of course, I'm lucky I have hospital systems, and both GE and Philips have very, very good automated, longitudinal strain. And, if you listen to the experts, the medical experts on strain, what they tell you is you should not try to readjust the whole area. I mean, when you try to adjust all those little segments in strain for tracking, you're going to get perhaps more accurate results, but they will be very less reproducible if you're following them over time.
Right.
And for the most part,
much human input to that, you mean?
That's right. The more human input you provide. So what they usually recommend is, if you're looking at the 3-point approach, make sure that your two basilar points are on the ventricular side of the mitral annulus and watch them track. Since mostly strain is measuring longitudinal shortening, it's really important to get as long of a ventricle as you can. That's one of the big areas, which a challenge for 2-chamber views, right? For 4-chamber, I think we do better. When you do a 2-chamber, which I do a lot for mitral disease, you tend to get some foreshortening, I think.
It's really hard to get a whole LV in that.
Yes, agreed.
A visual view of the mitral valve in that 2-chamber, I think.
Agreed. Yeah, and actually, for me, the commissural view of the mitral valve, something I've seen a lot at Colorado, where they're, of course, doing a lot of procedures, is to actually place the transducer slightly more dorsally and angle the heart. So instead of it being vertical, it's more angled, and then I think you get to see the P1, P3, and A2 a little bit better. But if you're doing, strain or volumetric estimates from 2-chamber, you really need to try to get it, as longitudinal as possible and as up and down or as apical basilar as possible. So, but what I do to summarize is if fractional shortening is not good, then I go ahead and I will do fractional area change. I will do a 1 or 2 plane ejection fraction. I'm not sure they're really biplane because they're not really orthogonal to each other. They're not. To me, a biplane is a 4-chamber and a 2-chamber from the left. But I do 2 planes if I can and pick the one with the longest length. And then I also will do strain. So I'll look at all of those. I use around -16, -17 global longitudinal strain as probably being normal for most dogs.
Right.
I think there's some different studies and vendor differences also exist, as I think you guys know. And then the last thing I do is I think what we did in that paper, and I didn't do this. I'll attribute this to Keith Blass, who was one of our multiple bright residents. I can tell you the story. So I was watching Keith as a 3rd-year resident measure fractional shortening. And I looked, I said, "What are you doing?" Because he was drawing a line between the nadir of the septum and the apogee or maximum excursion of the free wall. And he was just making that distance. So I said, "What are you doing?" He said, "Well, I'm so tired of having these borderline fractional shortenings. I know they're normal. I measure it this way now."
I'm going to make it
So actually, if you draw a horizontal line between the septum's excursion and the free wall excursion, you will actually normalize most fractional shortenings. Now, of course, we don't have normal data on that, although I did publish those 79 dogs with Lance, which were actually captured by Lance and measured by someone else, but someone very good. And I think that that's actually another way to try to correct it. And the biggest worry here, right, are beginners, right? Beginners or people who only do isolated echo, and all of a sudden you have a Doberman on pimobendan and other drugs for the rest of his life when maybe he doesn't need it. That's my concern.
Right.
Yeah.
Can we just get your thoughts, just going a bit back on assessing systolic function? So I think most people use injection fraction, using hopefully volumes and Simpsons. And so just to remind our listeners, injection fraction is a measure of global LV systolic function, which would include circumferential, radial, and longitudinal components contraction. What I would love to hear from you is if you have a normal injection fraction, when would you, with the normal injection fraction, still assess longitudinal systolic function, for example? And I ask you this because a conversation we had before, and something that sometimes is, in fact, not completely clear to me is, in case of HFpEF, in case of like hypertrophic cardiomyopathy, which are characterized by hyperdynamic systolic function, injection fraction will always be normal or hyperdynamic till very late in the disease. When we start looking at longitudinal systolic function, for example, is reduced. So I think my question is, do you assess longitudinal systolic function, for example, even if injection fraction is normal? But then if it is reduced, what's the impact? What is the impractical impact? What's your take from this case of HFpEF with reduced longitudinal systolic function?
We're talking mostly now about cats, I think, or perhaps and maybe an aortic stenosis dog, chronic or chronic systemic hypertension.
Yeah.
I think there you're going to look at diastolic function. But if you were to ask me what do I think happens to cats with HCM that go into heart failure, my belief is, and you know this because you've published on it, is I think many of them develop at least regional systolic wall dysfunction. And they don't even have to have obvious thinning. But, if you follow some of these old Maine Coon cats, their septum's still quite a bit thicker than their free wall. Their free wall now measures normally, but if you look at that wall just is not moving the way it should. So their fractional shortening is going to be normal because the ranges are too wide, and they probably should be hyperdynamic if they're HCM. But you see these areas of systolic dysfunction. So I think in a cat, I look at it probably differently than I do in a dog. Maybe I'm wrong about this, but if you look at old M mode studies, because I started with dedicated M mode where all we had was a pencil probe. And so when you look at almost all those old studies, the amplitude of the free wall is almost always greater than the amplitude of the septum. That's true in dogs. I don't know about cats because I never focused that much on systolic function in cats, except once taurine was, no longer an issue. We didn't care very much about systolic function. But I think that whenever you see the septum moving more than the free wall, the first thing I think about is it's probably volume overload of the LV, and it's pushing the septum up into the RV. And you see that with DCM, with PDA, with chronic mitral regurgitation. Because if you actually measure the amplitude of the free wall, even though it's less than the septum, it's often in the normal range from old studies measuring amplitude. So I tend to look at that. I tend to look as a sign of volume overload. In cats, I tend to look at how the free wall is moving relative to the septum. I think a lot of those end-stage cats, and of course, then they have a big left atrium as well, so it's not much of a challenge. This is a pretty knackered ventricle, and it's going to, probably lead to heart failure or thrombus. So I didn't answer your question about longitudinal shortening. I have to admit that if I have a normal ejection fraction and normal strain, I probably wouldn't focus that much on like MAPC. But I actually think MAPC is a reasonable thing to do, especially if you're following it longitudinally. And of course, my colleague at Ohio State, Carson Schober, published on mitral annular motion in dogs, decades ago. I mean, he was an early MAPC person, right? If you think about it. But like many of the studies, we tended to group, we knew they were body rate related, but we tend to put them in big groups. So they become very insensitive, right? So that's the problem is when you have big groups of body weights, you get a lot of insensitivity to detecting abnormalities. So that's a rambling answer about longitudinal function, I guess. But yeah, I think we need to look at longitudinal function. And I used to do mitral annular motion all the time in dogs. When I wasn't sure.
Do you still use M mode, and when would you recommend us using M mode?
So I'm of the school that if you measure an LV diameter in diastole and systole, whether you measure it by M mode, short axis 2D, or long axis 2D, they should be the same. There's no logical reason why a guided M mode should differ from the 2D. And it rarely does in short axis. Long axis is more of a problem. That's been published on. I think Carson actually published on that in Doberman's, showing some differences in minor dimensions by long versus short axis. And again, I think it depends partly on what error do you want to make. Do you want to, but I use the long axis 2D measurement as a check against my short axis measurement. What I caution beginners to do is to never use M mode, because I think you can make more mistakes with M mode. If you have a really good symmetrical LV at the high papillary muscle level, you should be able to just measure the LV and diastole and systole fine. It doesn't matter how much the heart is rotated. But if you're trying to drive an M mode cursor down the center of the ventricle, you're going to have to very often move your transducer cranially, angulate caudally, slide the image to the edge of the sector where you actually cut off part of the wall to get the cursor to go through, or else you can play with anatomic M mode and watch the horrible digitization of that signal, right?
That's the downside of it, isn't it?
Yeah. Yeah. So I think I still do M mode. Now, where I differ from some of my colleagues in the cat world is if I'm looking at a heart and it looks pretty symmetrical from a wall thickness, I will still do M mode, both in long and short axis. And I do that because it gives me great temporal resolution. All right. And so for me, the temporal resolution for a cat wall is critical. I've watched so many people. And if you, and Josie, maybe you've done this, or Kieran, you've done this, but if you do tissue Doppler on a cat and you time it to the QRS, in the real-time study, I'd freeze it, because I'm a little worried that sometimes when we digitize studies and go back, the QRS isn't in the right spot. And I actually think,
agreed.
I don't want to say which vendor that is, but you guys are familiar with this vendor. And sometimes it's like, what? Where's that QRS? And I remember Dave Sisson pointed this out a long time ago that didn't seem to line up. But if you're doing a real-time study, you freeze it and you do tissue Doppler. Isovolumetric contraction, to me, is occurring between the peak of the R and the descending limb of the R wave. So that's one of the reasons why I'm pretty sure our recommendation for end diastole is going to be the peak of the R wave. And not only that, because almost all the artificial intelligence algorithms that we use now are all using peak of the R wave. So unless you're going to manually move it, you're going to be stuck with the peak of the R wave. But I don't think that's a bad idea now that I look at tissue Doppler. Using the onset of the QRS actually was initially from ASE guidelines from the 1970s for dedicated M mode, and we just adapted those. But I think that we probably need to move on to the peak of the R wave, and you might argue in cats, maybe even a touch later, depending on your frame rate. But I'd be interested knowing what you guys think about that.
Well, it's really interesting. I mean, the tech has moved on so much, hasn't it? And the processing power has changed so much. But as you say, timing off the ECG only works if the machines get an ECG in the right place for it. So if it marries up with the image we're getting, and I guess freezing the 2D thumbnail to get your trace of TDI or whatever, Doppler, M mode, whatever, is super important.
So one place I really use M mode, and I'm not that adamant about much of anything anymore. I mean, I might sound like I am, but I mean, you make enough mistakes and you get yourself bruised enough over the years that I have opinions, but I'm not that dogmatic about things. But one thing I'm dogmatic about is we grossly overdiagnose mitral and tricuspid regurgitation, especially in cats, when we look at 2D color. And, especially in a non-hospital grade machine, you're getting frame rates sometimes of 14, 15 frames per second. And, you're lucky to get 6 or 5 frames for the whole cardiac cycle, which means that the data are going to be merged together. And I can tell you that in the old days of original color Doppler, when we had videotape, so we had 29.97 frames per second, you could literally see systolic and diastolic events on the same frame because you couldn't process fast enough. And so the same thing still can occur in color 2D. So what I try to teach residents is when you see a jet or you think you see a jet in a cat, put a color M mode on, put the M mode cursor through. And most of these blue flashes that you see are simply backflow noise. Many of them are pre-systolic. Many are occurring during isovolumetric contraction. This is not MR. That did not explain why your cat had a heart murmur. All right. And that's my point. I've seen cardiologists, say, oh, he's got an MR. And you go, yeah, time that, please. And then they time it, and it's not even in systole. It's not even for 30 or 40 milliseconds. That can't be the murmur that we're hearing, I don't think. So that's where I really like M mode, is for color. I still use M mode for temporal resolution, maybe because it's a tradition, but I don't care if you measure off 2D or M mode. It should be the same in my view.
I like you say that. I love color M mode.
Yeah, me too.
We use M mode for color M mode, but I think nowadays we use mainly M mode to assess LA fractional shortening
Yeah.
because we like it. It's easy, it's fast, and now that we also start looking at the
Yeah.
aortic root motion, I think it's just a nice measurement and an easy measurement to do. Can we just go back, maybe slightly more basic stuff, but I think hopefully will be relevant for our listeners. As everyone would know that is listening to the podcast, dogs have a wide range of body weight, so we need in some way to normalize or index our measurements to be able to compare them. Something that you have proposed, and your group has proposed, is to use echocardiographic ratios of using the aorta as an internal control in long axis versus short axis. Can you tell us more about that? What the advantages might be at using the aorta as an internal control measured in long axis and not in short axis?
In Lance's podcast, he discussed the differences between the aorta. So let's start there. So we all know that when you measure the aorta in short axis, you're going to include one sinus of Valsalva. Generally, you're going to include the far field, which is the left coronary cusp, right? And by the way, that's not what it is in a human. We don't do parasternal imaging like humans do. They come from the left. And their near field is the RV or RV outflow tract, not the RV inflow tract. And their far field is the non-coronary cusp, not the left coronary cusp. So I think that's important when you look. I remember, you want to talk about doing dumb things. I looked at that human M mode image for like a decade and wondered why I couldn't replicate it before I figured out, well, I'm coming from the right, you moron, not from the left. And that actually clouds a lot of things. I mean, if you look at short axis views, right, the heart's rotated, especially in dogs, their heart is rotated differently than it is in humans. So the posterior papillary muscle is actually closer to the transducer, not farther away, because we're coming from the right. So that's important for beginners to recognize is we're not going to replicate parasternal imaging. Our apical imaging is far more similar to humans. Going back to the question that I just diverted from. So what was that again? I was thinking too far ahead. So in the short axis, there's nothing wrong with measuring the aorta in short axis. And when I measure, for example, the pulmonary artery, I measure it compared to the aorta in short axis. If I'm doing LAAO short axis, which by far is the most popular way of doing it, but I'd argue most popular in part because it's been part of clinical trials. So once it's part of clinical trials, you have to do it that way.
You're kind of bound into it to make those decisions, right?
Right. That's right. Yeah. I mean, in cats, I think there's a lot of value in cats in that view because you see the auricle, right? You don't see the smoke or thrombus as well as you do from the left side, but you definitely do see the auricle. And I know that you guys have talked about that. But so in the long axis, the reason I started doing this was, and so I'm not going to throw stones at the Cornell meta-analysis, okay? Because like most meta-analyses, the math is done perfectly, right? So you can look at, Jens's big study with cats. The math is done perfectly. He's a brilliant statistician, right? Craig Cornell, I believe, was an anesthesiologist who did the stats for everybody. He's not a cardiologist. So we call it the Cornell analysis, but really he was given data by lots of cardiologists. Right? You can look at the Esser study, right? That's another study. So the maths are usually done perfectly. You could argue about how you deal with bigger body weights. I think there is an issue dealing with bigger body weights, and there are adjustments that probably should be made when you're normalizing to body size, when you're doing a multi-breed study. But I was looking at the Cornell reference limits, right? The 1.85 normalized dimension, that's a 97.5 percentile in that study. And I look at these hearts and go, give me a break. That heart's enlarged. And yet it's still within the meta-analysis reference range, right? The 1.85 normalized dimension. Well, the problem is not the math. The problem is the sampling. If you dump 140 Irish Wolfhounds on 100 Cavaliers into a study, you're going to skew the results. And this is my concern about most reference studies. If you do 10,000, 20,000, 30,000 cats, but you a priori exclude cats that are more than 5.5 millimeters, now you have normal values that are extremely probably accurate, but for cats that are less than 5.6 millimeters. And so these are challenges. When you do, if you look at the Esser study, what I really liked about the Esser study was they went ahead and they took out the sighthounds and looked at them separately, right? And if you look at their their prediction limits for individual breeds, you can see some breeds fit right in the middle, including Cavaliers, right?
Right.
And others actually hover on the edges. So I think it's usually not the math that's the issue. I think it's the sample. And to me, that's the problem with lots of veterinary research. It's not paying attention to what the sample is as opposed to how it was analyzed. So what I think about normal values, I think in a perfect world, we would have breed normals arranged or contributed by at least 5 to 10 institutions with cardiologists who've discussed in advance how they do it. There'd be a core lab to take samples from each of those institutions to see if they got the same values, or I'd have all the measurements done at the core lab and just like they do in
Just
humans.
centralize
Right?
it.
Just use it centralized in the core lab. And then I would probably do, if you had enough, I'd probably do, if the data is normally distributed, I'd just do the 2.5 and 97.5 percentile approach. If I had smaller samples, I might use robust bootstrapping. I like clinical laboratory standard institute methods. I mean, you can do that easily in programs like MedCalc. So if you've got 50 well-described English bulldogs and you do CLSI, you're probably going to get, especially with bootstrapping, pretty reasonable limits for reference. I think the bigger challenge, and I know you and Lance discussed this, was when you have mixed breeds and you have to use multi-breed normals. And there, I think the Esser paper nicely showed that you need to take out the sighthounds or certain breeds. And I think Dave Dixon has shown that, right? English Spaniels, right?
Springer Spaniels,
Right?
yeah.
Yeah. So there are always going to be exceptions. That's why I think just having normal values for every breed is important. So back to the guidelines, we are not going to say which values are normal, because I think we can find potholes in every one of them. But I think we're going to reference them, but we are going to be fairly specific about how we believe we should measure in the future. And we also have a little blip. We're running out of space for these guidelines, but we have a little blip about what we think should be done in the future to establish guidelines. Not that former studies have no value, they do. I mean, they have great value. Look, I mean, the Cornell study showed us very clearly the nonlinear relationship between body weight and some of the linear indices. That was really
There's so
important.
much built on that, isn't there?
Yeah,
That's the foundation. And actually,
right.
the
Right.
foundation doesn't have to look perfect now from the
That's right.
outside. It's just
Totally.
got to allow us to go further.
Right. And it did. And I think it's really important. And of course, I program some of our reporting functions, and I program in Esser, Visser, and Cornell exponents. So pick your exponent. But I think if you're doing myxomatous mitral valve disease, you've got to use the Cornell exponents, right? Because that's what was used for the study. But if
Right.
you're asking me what's a better way to detect cardiomegaly, I would say Visser or Esser, because I don't think the Cornell is sensitive enough. That would be my basic point. As far as measuring the aorta, the reason I measured it in long axis was because I was trying to find a simple way to do left atrial to aortic ratios and left ventricular aortic ratios. Most non-cardiologists started learning long axis first, many of them in the US, and especially radiologists. The person I worked with, Logan Strom, was a great radiology resident and who knew a lot about cardiology. And so we used long axis images for those indices, but they should have worked just as well for short axis if you've done the imaging properly. And the downside, of course, would be those breeds who might have a small aorta or or diseases that might cause a dilated aorta. But you could argue the same thing is true for short axis, right? It's going to affect the aortic root as well. So nothing's perfect. And also I do multiple ways. So I mean, I know you've talked about this, but I'll measure the LV and the LA multiple ways and look at it subjectively. I mean, these are all things that I think most cardiologists do.
You were talking there about the idea of generating reference intervals and centralizing measurement in order to remove some of the bias. What about AI measurements in terms of moving bias or removing bias from the measurement. What are your thoughts on where we are with AI in echo at the moment?
Well, so we have to use AI for strain, right? I mean, it's a black box.
It's true.
So,
Yeah.
but I actually think that if you don't over manipulate the region of interest, that you get fairly repeatable results. So for tracking, like for doxorubicin patients, I think that's pretty reasonable. All right. So, of course, with the Philips system, I think with the GE, but I'm not positive. When you do strain now, you also get an ejection fraction. So
yeah, it's a separate
yeah,
button on the GE, but it's the same idea as that
right.
second layer of the Philips. Yeah.
Yeah, and so it's speckle track based, and so
Yeah.
I do look at that. I think that's fairly accurate. I mean, if you watch the tracking now, I worry about systolic tracking mostly for strain, and I think that's what the experts say. But for ejection fraction, I do worry about both diastolic and systolic tracking. So might make a few more adjustments there. But I think for ejection fraction, probably it's okay. I have used the GE and the Philips auto Doppler measurements. Those AI algorithms have a very vivid imagination, I would say. They are sometimes right on, but they are so often wrong. So I think, unless you're going to have a perfect spectral Doppler signal, you're going to have trouble. And especially like in a cat where you might have really small, low velocity tissue Doppler, that may be outside the realm of what the algorithm is looking for. I know when I've tried to do strain initially in cats, it would say that patient's too small, right? It wouldn't do it. But these are also somewhat vendor specific. Then that brings me to the point of instrumentation. So like one of the things that I would say residents know very little about, and maybe some cardiologists too, is how to tweak your machine. So when I go to an institution, usually the first thing I do is make new presets. I start with what they have. But my biggest worry is actually with Doppler, the old chin and whisker issue. But what the first thing people should do is find the power button, because power and gain, or transmit and gain, are two different things. And actually, we have quite an extensive table in the guidelines on instrumentation. And while we're not able to include, we were not able to include Doppler in these guidelines, which is crazy, but we've buried it enough in there. There's a lot of Doppler in there that you'll be able to find anyway. But in terms of instrumentation, what I would say is start by finding the power button, which is usually on page 2, and turn it down. It's usually way too high. And then find the frequency adjustments for that transducer and see which ones work best. Many times we think the lowest frequency will work best, but it doesn't. Especially in cats, I would be turning it up to the highest frequency for that transducer in most cases. And it's done automatically with tissue Doppler, but not automatically when you're doing spectral Doppler. And then I would control the sample volume size. The default sample volume is usually 4 millimeters, which is too gigantic for most critters we deal with. And then I would also turn the gain down, and also look at the compression and grayscale. All of those will adjust how your Doppler spectrum appears. And, I'm looking for a nice modal velocity just below the envelope, and I'm looking for grayscale. If I'm not seeing shades of gray in my Doppler, I think it's a bad Doppler. And so that would be something I would encourage people to do, to work with their software or with their, echo vendors, the application specialists, to learn how to get into those menus and adjust those. Don't just accept what the preset is. I always want to talk about that, because that's the first thing I do when I go to somebody's system is I just start adjusting all the buttons. Yeah.
But thanks for that. That just reminded me, when you visited Zurich, when I was there, you I think went there to visit Colin, and you were kind enough to come over and see some of our cases. And then you start playing. We thought our presets were perfect, and then you start playing with one of our probes, and you made it so much better. We call it the JB was here preset. So,
John, just thinking about advanced echo techniques, do you think, with regard to systolic function particularly, there's a place for three-dimensional echo techniques at the moment?
I'd say at the moment it's probably pretty limited. I think the problem is the transducers are just too powerful and the frame rates are too slow. The processing is too slow. I mean, clearly, if you're doing interventional procedures, having 3D on your transesophageal scope is really helpful, both for procedures like a mitral clip or even just simple procedures such as, stent guidance or PDA, device deployment. Where I think 3D is quite helpful. For routine studies of 3D, especially for volumes, I think we probably have a long way to go, but I think it's mostly related to the instrumentation. I have not tried the newest GE pediatric 3D probe. I've heard that's pretty good. We have Philips 3D probes, and they do a good job, but their frame rates are pretty slow, and I'm not sure they add that much to the 2D assessment right now.
That seems to be the problem at the moment, isn't it? Is the processing power of the machines actually not the 3D technology?
Yep, exactly. Yeah. So if you were asking me, do we do it routinely at North Carolina or at Colorado? No. And when I go to Ohio State still occasionally, and that's not routine there, but of course in the cath lab it is routine.
Yeah, context is different there, isn't it?
Yeah, totally.
Brilliant, John. And maybe to finalize our podcast, could you? I'm sure it's really difficult to pick a highlight of your career or the best memory, but maybe could you share with our listeners maybe one or two highlights of your career, or a funny memory or a nice memory you have that you could share with us?
That's, of course, is a tough one, but if I were to encompass many memories into one theme, it would probably be traveling to countries outside the U.S. I don't think anything has been more formative for me as a person, and maybe professionally as well, as just traveling elsewhere, both teaching and learning. I know this broadcast comes from the UK, and I'm certainly not trying to pander to that audience, but I did live in Scotland for a year, and I traveled anywhere anybody invited me. So if they invited me to speak anywhere in the UK, I would go. And then I would look on the map to see where it was and say, oh, that's in Cornwall, but I'm going to go anyway. But one memory that always I talk about is I was in the Southwest, and I spoke. This is still at a time before we had PowerPoint. So I'm projecting slides through a room filled with cigar smoke and cigarette smoke. And I gave my lecture, I think it was about heart failure in dogs. And at the end of the session, they literally passed the hat to pay for my travel expenses. And I thought, well, this is not going to work. But in fact, it did. It was more than enough. And I think that encompassed perhaps my international experiences, that you don't necessarily expect what's going to happen, and it's so enjoyable when you experience these things. So, as you know, I'm getting to come back for the 50th of the Veterinary Cardiovascular Society, and I've so valued my relationships in the UK and many of the people I've worked with and met, and just the country itself. So, I think travel probably for me may be my single greatest experience. And then I'll leave you with one last experience that probably isn't what you would think about, but at Ohio State, for the longest time, we had this large coffee urn in central supply where you would get the catheters and other things. And I would always go in for my last cup of coffee around 4:30. And I'd look at the clock and say, oh my gosh, it's 4:30. I have so much more to do, excitedly. And I'd look at the folks working in central supply who I was friends with, and they'd be looking at the clock thinking, when can I punch out? And I remember thinking, how lucky am I to not be looking at the clock to have to leave my job? I have the great job, and I still have a great job. So those would be maybe two memories I'd leave you with. Thanks.
Brilliant. Fantastic. John, this was truly outstanding. Really, thank you. Thank you very much for joining us today. Thank you so much. It's an honor, genuinely.
Pleasure. Great to see you. Great to see you. You still look young, really young.
I have a filter. It's a filter.
Okay.
Thank you indeed for everything you have done, and we look forward to read the guidelines. Thank you.
Thank you. It's a pleasure. Thanks so much for having me.
You have been listening to the Animal Heartbeat. Thanks very much for our listeners. Keep in touch by finding us on social media or sending us an email on animalheartbeat@gmail.com. Please remember to like, follow, and share to help us find new listeners. And make sure to check out our previous episodes wherever you get your podcasts from or on our YouTube channel.